Hi, I'm Dan Barnett from Johns Hopkins Bloomberg School of Public Health, Department of Environmental Health and Engineering. And in today's presentation, I'm going to discuss deliberate events involving chemical agents and the acute outcomes of such events. This is part of the Program on Occupational Health and Safety Education on Emerging Technologies, Mid-Atlantic Partnership, or Pocket Map. And this topic is very relevant as we face an ever-broadening array of threats, including chemical threats, to population safety and health. Let's begin with a key definition. What do we mean by deliberate events when we talk about chemical events or other types of intentional events? In this case, we're talking about an act or threat that involves the intentional release of hazardous substance to cause harm. So this is in contrast to technological accidents, for example, that may result in release of chemical materials. Instead, we're talking about intentional releases. The scale of the release matters. And when we talk about chemical terrorism, we're talking about everything from small-scale emergencies, such as contamination of a product intentionally designed for purposes of extortion, for example, to large-scale events, including intentional release of hazardous substances deliberately intended to kill or injure people or destroy animals or crops, or both. Let's talk about some characteristics now of deliberate events, and then we'll get into more detail regarding chemical aspects of them. So when we think about deliberate events, we have to think about public risk perception and concern. The intentionality of an event, whether it's chemical or other, makes the risk perception high and the level of concern very high accordingly. And this level of concern is exacerbated by what's often a lack of familiarity about the specific hazards among the general public. There's also the issue of concern regarding the impacts on health for future generations. So while in this presentation we'll be talking about acute health effects, it's important to think also about longer-term implications in terms of health. Deliberate events can affect both the intended target and bystanders indiscriminately, and of course contaminate the environment. And the impact, very importantly, may continue for a very long period of time after the event. Many, many years, for example. Also, the victim can be a perpetrator. So if someone releases a chemical agent, that person may succumb to the effects of the chemical release. So let's talk now a little bit about the history of chemical weapons use, because it's important to situate our understanding of current chemical threats and their acute effects against an historical backdrop. So when we think about modern chemical warfare, we can look back at World War I and World War II, where we saw the use of chlorine and phosgene gases. In the Cold War, both the US and the former Soviet Union stockpiled chemical weapons. We also, in the context of Iraq, saw mustard gas and nerve agents being used in Iran and against the Kurdish people in the 1980s. And more recently, in the Syrian civil war, we've seen the use of sarin, chlorine, and mustard gases against civilians and military personnel. When we talk about intentional chemical weapons use, we can think about events even involving, for example, religious groups. In the case of Japan, there was a group called Aum Shinrikyo that in 1995 attacked a Tokyo subway using sarin gas, which, as we'll discuss, is a nerve agent. This attack killed 12 people and seriously injured 50. ISIS, more recently, has used chlorine and mustard agents in Syria and Iraq since 2014. We've also seen other states' use of chemical agents. North Korea, for example, we saw a poisoning with a nerve agent called VX of a relative of the leader of North Korea in Malaysia. And in the case of Russia, there was the use of Novichok, which is a nerve agent that's been used to poison opposition figures. So it's important to understand these historical contexts in order to understand present-day threats. One example that we can contextualize further in terms of present-day threats is the agent called Novichok, which I mentioned a moment ago, has been used against opposition figures by Russia. And this is an advanced nerve agent that was developed in the former Soviet Union during the Cold War. It's reportedly up to 5 to 8 times more lethal than some very powerful nerve agents, such as sarin or VX, that we'll talk more about. It evades standard chemical detection, which makes it a particularly heightened concern. And it penetrates personal protective equipment and is resistant to treatment to a large extent. So these are the kinds of evolving threats that we have to think about when we consider chemical weapons use and, as we'll discuss, their acute health effects. Let's talk about motivations for use of CW or chemical weapons. Strategic and asymmetric advantage over an adversary is one motivation for the use of a chemical weapon. And as depicted here, this can be either an intent to kill people at a distance. It also has psychosocial impacts, causing fear and confusion in addition to the physical casualties. And it can be either used for mass effect or covertly for assassination. So we see a wide variety of potential uses for it, unfortunately. And there are also global norms against the use of chemical weapons, which means that they garner a lot of attention. And when we think about global norms, we think about the Chemical Weapons Convention, for example. This is a very useful slide, I think, because it helps us compartmentalize the different types of chemical agents that we need to be mindful of when we think about intentional chemical releases and their acute health effects. So I'd like to begin with what chemical agents generally would be if they were used for intentional harm. Those would be what we call lethal agents. So you'll see on the left side of this slide a box that says lethal. So everything under lethal that I will discuss in a moment could be an agent that might be used in an intentional chemical release. It's unlikely that we would see incapacitating or riot control agents that you see here on the right for an intentional release. So we're going to focus accordingly on lethal types of chemical agents. And there are two broad categories of lethal chemical agents, and we'll take these in turn. The first are industrial chemicals. So if you go to the bottom left of this slide, you'll see listed at the far left box in the lower left-hand corner, choking agents. These include chlorine and phosgene. These are gases that cause acute respiratory distress. In the case of phosgene, it can cause what's called pulmonary edema, swelling, and also can cause basically overwhelming of the lungs. And that's why we call them choking agents. To the right of that, you'll see a box that says blood agents. One way to sort of recognize a blood agent is if it has the word cyanide or some variation of the word cyanide, in this case, hydrogen cyanide. Why is that relevant? Well, blood agents, what they do is bind to hemoglobin, which is the oxygen-carrying molecule in the blood, and by doing so, they impair the delivery of oxygen to the tissues. So those are called blood agents. To the right of that box is nerve agents. As you'll see under industrial chemicals, which is where we are in this diagram, pesticides are nerve agents that theoretically could be used for intentional harm. Let's now move to warfare agents within the category of lethal agents. There are two broad categories of warfare agents. The first on the left here in the bottom right corner of the screen is blister agents, and these cause damage to the tissue, external tissues and mucosa, sulfur mustard, nitrogen mustard. So typically if you see the word mustard, you are most likely looking at a blister agent. And then last but not least on this slide, in the bottom right corner, we see nerve agents. And these affect the synapses between nerves. And they include sarin, tabun, soman, GF, and VX. Sort of a rule of thumb of if it sounds sort of like a word that doesn't call to mind a typical chemical, or if it's an abbreviated term like GF or VX, we're most likely talking about a warfare nerve agent. Importantly, warfare agents are only used for lethal purposes. They have no industrial use. So that's important to distinguish industrial chemicals that I mentioned a few moments ago from warfare agents in the context of chemical agents. Now let's talk a little bit about the impact, symptoms, and treatment following intentional chemical release of an agent, whether it's in this slide, we'll talk about industrial agents, and in the next slide, we'll talk about warfare agents. So let's talk about industrial chemical agents. One of the key rules of thumb is the time to onset of symptoms varies between different types of agents. So let's take the first row, choking agents. We talked about chlorine and phosgene as examples of them. The time to onset can be anywhere from 2 to 24 hours. Typically, the shorter time to onset, the higher the dose that's been received of a chemical agent. The first symptoms we would typically see following acute exposure to a choking agent would be cough and shortness of breath, and treatment would be decontamination and supportive care. Rule of thumb in emergency medicine is ABC: airway, breathing, circulation, in that order. When we talk about supportive care, we think about those kinds of things and other additional supports. In the middle row, we're talking about blood agents. So the time to onset for a blood agent, and you'll recall that we discussed how if you see the word cyanide or variation of cyanide, you're typically looking at a blood agent. The time to onset following exposure to a blood agent is typically immediate. The first symptoms will manifest as dizziness, nausea, or weakness. And the treatment for blood agent acute exposure is decontamination, and there is an antidote called amyl nitrite. In the bottom row, we're talking about industrial nerve agents. And typically the time to onset following acute exposure to industrial nerve agents is 30 minutes. You'll see a variety of initial symptoms such as pinpoint pupils, runny nose, and shortness of breath. And the treatment, again, is decontamination and atropine. So I want to highlight that for all of these agents, you'll notice the one common theme is decontamination is critical. Now let's talk about various impacts for low versus high exposure of warfare nerve agents. When we talk about warfare nerve agent, the form of the agent matters in terms of the health effects. So let's talk specifically. If it's in a liquid form on the skin, the symptoms would typically appear between 30 minutes to 18 hours following exposure. At a low exposure with liquid on the skin, we typically would see sweating and twitching at the site. And at higher exposure following liquid on the skin, we would see nausea, vomiting, diarrhea, convulsions, and even death. Now let's look at the bottom row where we talk about vapors. So you'll see that these agents, when in vapor form, have much more rapid initial effects. The symptoms appear between a few seconds to a minute following exposure. And at low exposure, you'll see pinpoint pupils, salivation, runny nose, and cough. And at higher exposure, we see convulsions, paralysis, and death. So this slide and the preceding one really are important because they highlight time to onset and the various implications for acute exposure. Other considerations regarding chemical agents and acute health effects relating to them. So when we think about chemical exposures and intentional releases of chemicals, we have to ask a few questions. These include a where question and a couple of how questions. So where will it be in the environment? Most chemicals that we're concerned about are heavier than air, so they typically sink to the ground. So a rule of thumb, there are exceptions, but in general, a rule of thumb is we want to be higher up in terms of uphill or upwind. So the word up is very important. And so where it is in the environment matters. How long does it stay in the environment? Half-life, for example, how toxic is it? All of these are critical acute considerations following chemical releases. The route of exposure, as we saw in a preceding slide, if it's a contact via skin versus inhalation, it makes a big difference in terms of health effects. Ingestion is another possible consideration, and traumatic wound entry, so basically absorption through cuts or open wounds. Let's talk now about additional health impacts when we talk about chemical exposures. And we need to think about a few different categories of health impacts here. These include poisoning. So these chemicals are poisons that we're talking about, and so we need to think about them as such. Some of these chemicals can cause burns. Some of them also can impair the immune system, damage the reproductive system. We also have to consider longer-term health effects, including cancer, which can take decades to manifest following chemical exposures of certain types, and traumatic injuries. If there was an explosion coupled with a chemical release, we have to think about that also. Burns are a form of traumatic injury, as we saw earlier on this same slide. Let's talk now about detection of cases and events. And there are two broad categories of surveillance that are really important when we talk about gauging and monitoring for chemical intentional releases and their acute health effects. The first broad category is what we call indicator-based surveillance. This is what uses structured information, so syndromic surveillance, monitoring of patients who present with certain unusual or concerning signs and symptoms in a hospital setting, for example. and case-based surveillance, which involves clinical and laboratory elements. On the right-hand side of this slide, you'll see a different category of surveillance called event-based surveillance. And the key difference between indicator-based surveillance and event-based surveillance is that event-based surveillance uses unstructured information. What do we mean by that? We mean hazardous materials release and reports of that. Information from security and law enforcement about concerning release, for example, of a chemical agent in a subway, or even monitoring social media to detect whether something may have occurred. So the key difference again between indicator-based surveillance and event-based surveillance is that indicator-based surveillance utilizes structured information, whereas event-based surveillance utilizes unstructured information. Possible indicators of a deliberate chemical event are able to be categorized in different aspects. So for mass casualty incidents, possible indicators could be an explosion or fire, proximity of unexplained dead animals, of various types of animals, or birds are an example where we can see proximity of unexplained dead birds, abnormal odors, unusual fogs, clouds, or mists. All of these things can be tip-offs that we are dealing with a mass casualty incident, and obviously with an explosion or fire, it's much more dramatic and obvious. But even things like abnormal odors and unusual fogs and unexplained dead animals can also help us assess whether something has occurred. Unexplainable illness, things that just don't fit with typical biological routine events, would be a possible indicator of a deliberate chemical event. Peculiarities of the clinical manifestation, that relates to the last bullet on this slide. And a peculiar number or timing or distribution of cases. So lots of people having seizures in the same location or approximate location at a particular time. That could be a tip-off that we're dealing with a chemical acute exposure. Let's think about some other features of chemical events that are relevant to our discussion. So there is, as we talked about, a brief acute phase involving direct exposure. There can also be something called off-gassing, which is a form of secondary spread to first responders and healthcare providers from victims at the scene who have been contaminated. So one of the first steps in decontamination is removing clothing that could be the source of off-gassing of these chemical agents. Also, there are psychosocial considerations, the fear and horror or outrage, it's sometimes referred to, that would be attached to psychological response at the time of the event. Longer-term sequelae, longer-term health effects, longer-term physical and mental health effects. And we can't forget about the stress that responding to such events would present to healthcare providers, including what we call surge capacity, mustering up enough personnel to manage the event, and the emotional toll on first responders. So let's talk now in a little more depth about the public health and medical response. So as I mentioned in a preceding slide, one of the common themes as a first step following a chemical exposure is decontamination. And that's why it's highlighted here. We also have to think, as I mentioned earlier, about airway, breathing, and circulation, ABCs of supportive care and related interventions. And in some cases, when applicable and when available, there are potential medical countermeasures, albeit limited, that could be used for certain types of acute chemical exposures. Now, I've mentioned a lot about decontamination, and I want to highlight various modes of decontamination that can be utilized. So one example is physical or chemical destruction of the chemical agent. Another is isolation of the agent, washing the agent off the skin or body, absorbing the agent, and evaporating the agent. So these are all different modalities, but one of the key themes that we talked about, and I want to reemphasize here, is removal of contaminated clothing. Very importantly, people in health departments, unless they are hazmat trained, should not be coming to the scene of an incident to do decontamination. And as I'll talk about in an upcoming slide, victims who have been exposed to chemical agents acutely should have already been decontaminated before they reach the emergency department, because otherwise now the hospital or other facility becomes a threat due to off-gassing itself. So what I alluded to a moment ago relates to this slide. So when we think about management of chemical casualties, I want to highlight something I mentioned earlier, which is the word up. So there are three broad categories of areas or zones that we need to be demarcating clearly following an acute chemical exposure. The hot zone is the area immediately around the hazard site, and that is then followed by the warm zone, which should be uphill and upwind of the hot zone. Again, you see the prefix up, which matters because most chemicals are heavier than air, so they sink to the ground. So you want to be uphill and upwind, obviously, as well. You never want to be downwind, and that's important. So in the warm zone is where patients are brought by hazmat personnel for decontamination. The cold zone is where patients who have already been decontaminated receive further treatment. And as I alluded to a moment ago, the emergency department should be a cold zone. We should not have patients who are contaminated in the emergency department because there can be secondary contamination from off-gassing that could incapacitate or even kill healthcare responders in hospitals otherwise. As I had alluded to previously, the time to onset of symptoms can be indicative of the extent of exposure. So the shorter time to onset, typically the higher the exposure. And very importantly, we may need to monitor even initially well-appearing people following a chemical event for up to 24 hours because it can take sometimes up to 24 hours for initial symptoms to manifest. And that's still within the acute health effects time range. Let's briefly talk about some chemical weapons or CW medical countermeasures. The U.S. Department of Health and Human Services stockpiles antidotes to some chemicals, including nerve agents, using something called the Strategic National Stockpile. There is a component of the Strategic National Stockpile called ChemPack, and those ChemPacks are forward deployed to locations around the country, which enables more rapid response. And there are some antidotes, as I had alluded to earlier, for some nerve agents and other chemicals, and those must be administered within minutes to hours to be effective. So this needs to be a rapidly mobile and agile response using these critical resources when applicable. And chemical mass casualty management, or MCM, effectiveness also depends on the exposure dose. So if a person receives an overwhelming dose, regrettably, it will be very difficult to administer an antidote in time. So that concludes our discussion of acute health effects and acute aspects of intentional chemical exposures.